Hi everybody, welcome again to Dr Manny's YouTube Learn Shops. This Learn Shop deals with life support. This Learn Shop is adult life support, and this is part 1, which will look at basic life support methods. The learning objectives for this session will be just to briefly review cardiac and respiratory anatomy and physiology, look at the pathophysiology in the form of unstable angina pectoris, then review respiratory failure, basic life support, the CAB sequence, 1 and 2 rescue or CPR techniques, and CPR sequence. Cardiac equals heart. The heart is a muscular pump. It's an organ located in the midline of the thoracic cavity, just under the sternum, the breastbone. Essentially, it's a pump beating about 60 to 100 times per minute. It receives deoxygenated blood from the body, recycles it in the lungs, and then supplies reoxygenated blood to the body. Now, the normal cardiac location typically will be the apex is located in the 5th intercostal space in the midclavicular line. The base is located in the 2nd intercostal space substernally, beneath the sternum. Now, normal cardiac requirements. Note, the heart is totally dependent on oxygen and high energy phosphates for normal function. No oxygen means no pumping. Decreased oxygen to the heart means ineffective pumping. If we look at an adult, 70 kilograms, normal, cardiac output and metabolic requirements basically are equal to about 7 litres per minute, which is the equivalent to 100 mils per kg per minute. It can vary, but this is typically. Now, it's important for you to remember that when we talk about cardiac output, the amount of blood pumped out by the heart each minute, the normal distribution, where it goes. Well, the brain receives about 1,050 mils per minute. That's 15% of normal cardiac output. The heart receives 350 mils per minute, which is about 5% of normal cardiac output. The lungs, 2%, skin, 10%, kidneys, 25%, liver, 30%, skeletal muscle and all the other organs, the remaining 13%. In total, the cardiac output is approximately 7,000 mils per minute, of which the brain requires 1,050 mils, the heart 350 mils for normal functioning. Note that. When things go wrong, a 70 kilogram adult with effective external cardiac compressions only receives about 10 to 15% of normal cardiac output, which is 1/10 if you look at the figures there, 700 mils per minute, which is the same as 10 mils per kilogram per minute. Previously we said for normal cardiac output we require 7,000 mils per minute, not 700 mils per minute. Now note, with effective, which means you're doing it properly, external cardiac compressions, you're only getting 10 to 15% of normal cardiac output. So where does that cardiac output go with effective CPR? The brain is receiving only 150 mils per minute, 15%. The heart is only receiving 35 mils per minute, 5%. Lungs, 2%, remains the same, but only 14 mils per minute. Skin, 70 mils per minute. That's why it's cold, pale, and clammy. Kidneys, 175 mils per minute, no urine output. Liver, 210 mils per minute. Skeletal muscle and other organs, 91 mils per minute. In total, 700 mils per minute with effective cardiac compressions. So make sure that you do it properly. If we looked at the pathophysiology related to adult cardiopulmonary arrest, it's primarily related to atherosclerosis. And atherosclerosis typically results in endothelial dysfunction, the formation of plaque, and obstructive atherosclerotic lesion and plaque that results in a thrombosis, coronary artery disease. If we looked at the pathophysiology in more detail, briefly though, we're looking at unstable angina pectoris. Unstable means uncontrolled. Angina pectoris, pectoris is chest. Angina means strangling from the Latin. So angina pectoris is a strangling sensation that you feel in the chest. And with the diagnostic findings, it's described as a sensation of heaviness, pressure, squeezing, constriction, ache, or crushing, and it's located in the chest, typically centrally. Now, people often call it a pain, but it isn't really a pain. It's an area of discomfort, which typically occurs on the left side of the chest, sometimes with radiation into the left arm. When we look at unstable angina pectoris, it can be described as non-ST segment elevation myocardial infarction, or NSTEMI. And this is found on ECG electrocardiographic recordings. And it's represented by ST depression, more than 1 millimeter below the isoelectric line. It can also be ST segment elevation myocardial infarction, STEMI, which results in ST segment on the normal ECG complex being elevated more than 1 millimeter, 2 millimeters above the isoelectric line. Then you can have a third component in relation to diagnostic findings, Q-wave myocardial infarction. Now, typically we don't call it Q-wave myocardial infarction anymore, but I'll continue to use the old term. And this will be demonstrated by a Q-wave, which is a negative deflection after the P wave or in front of the R wave, if there is an R wave. Now, with unstable angina pectoris, the laboratory findings, I've only included 2 here, but there are numerous others. Cardiac markers, which is troponin 1. And troponin 1 is sensitive to small changes. Normal is typically 0.0.1 nanograms per mil, which elevates within 3 to 6 hours and remains elevated for about 2 weeks. Why does it elevate? Because the myocardium has been damaged through ischemia, through infarction. Then you've got another cardiac marker called CKMB, creatinine kinase myocardial band. And this is sensitive to big changes. The normal range is typically 0 to 0.4 nanograms per mil, and it elevates within 4 to 6 hours and remains elevated for 4 to 5 days. Why does it elevate? Again, the myocardium has been damaged. Now, what's the immediate management of unstable angina pectoris? It's always important to get a brief targeted history, do a rapid physical assessment, obtain vital signs, provide IV access in case there's a problem, do cardiac monitoring, and be familiar with the acronym MONA, which stands for morphine, oxygen, nitrates, and aspirin, which we'll be covering. Here we have the immediate management. Aspirin, 162 to 325 milligrams, or the equivalent. It's withheld if there's an allergy status which is positive. Then you've got oxygen. Oxygen is delivered at 4 litres per minute, or the SpO2 is less than 94% on air, or they are demonstrating angina or respiratory distress. Then you've got nitrates, which can be sublingual or a spray. And the maximum is recommended at 3 doses, and then if nothing helps, seek medical advice. Withhold, however, if the blood pressure is less than 90 millimeters of mercury systolic, because this is an indication of hypotension. Morphine. Morphine intravenously, well, you have to get that in a hospital, in an emergency department. Typically it's given between 2 and 4 milligrams as required, and withhold again if the allergy status is positive, the patient is hypotensive, less than 90 millimeters of mercury systolic, they have respiratory depression, or they have bradycardia. Certain management adjuncts such as 12-lead ECG, chest X-ray, echocardiogram, interventional cardiology such as cardiac percutaneous interventions, cardiac catheterization, MRI, CT, magnetic resonance imaging or computerized axial tomography, fibrinolytic interventions, intra-aortic balloon counterpulsation, coronary artery bypass graft surgery can all be adjuncts to provide management options. 12-lead ECG can indicate non-STEMI or STEMI. Have a look at the Dr Manny Learn chops on ECG. Simple and straightforward. Then you've got chest X-ray, which can show cardiomegaly, heart failure. Have a look at the Dr Manny Learn chops on chest X-ray interpretation. Simple and straightforward. Then you've got an echocardiogram, which can show valvular problems, filling problems, can work out things like ejection fractions. Then you've got cardiac catheterization, which can show obstructions in the coronary arteries. Other indicators on treatments can be percutaneous transluminal coronary angioplasty and stenting, but it's important to make sure that it is done within the window of 90 minutes from the onset of pain, otherwise it may not be as beneficial in saving myocardium. Here's an example of percutaneous cardiac intervention, pre-percutaneous transluminal coronary angioplasty with an LAD occlusion, and then 15 minutes after stenting, the blood vessel is open and perfusing. Then you've got management options which include fibrinolytic medications, but remember they have to be given within a window of 30 minutes from the time of pain onset, otherwise they may not be as effective. And their job is essentially to dissolve a clot. Tissue plasminogen activator, TPA, in this image, and it's restored blood flow. Have a look at the Dr Manny Pharmacology Learn chops and look at these interventions. Then you've got unstable angina being supported with intra-aortic balloon counterpulsation, which is a support device for the left ventricle temporarily. Have a look at the IABP, intra-aortic balloon pump counterpulsation Learn chop, which is in the Dr Manny Learn chops. Simple and straightforward. Then you've got management adjuncts, which could be cardiac surgery, coronary artery bypass grafts, and there will be a Learn chop on coronary surgery in the future. In progress now. When we look at the lungs basically mean breathing. The respiratory tract consists of the mouth, nose, trachea, bronchi, bronchioles, and the alveoli. Oxygen and carbon dioxide are exchanged between the alveoli and the capillaries. The main organ, however, is the lungs. Other respiratory organs can include the breathing muscles, such as the diaphragm, and the intercostal muscles, internal and external. Now, the lungs are typically found in the chest, on the right and left side. Anteriorly, they extend from the clavicle to the 6th rib, and posteriorly in the chest, the lungs end at the 10th rib. An adult typically breathes at a rate between 12 and 20 breaths per minute. Note, a respiration rate less than 12 or more than 25 breaths per minute while resting is considered abnormal. A normal SpO2 is usually 94 to 100%, and an FiO2 at 0.21 or air at an atmospheric pressure of 760 millimeters of mercury, sea level. Now, when we look at certain conditions related to the airways, foreign body airway obstruction, choking, is a problem. Common causes of choking are trying to swallow large pieces of poorly chewed food, drinking alcohol before or during meals, and this is problematic because it dulls protective reflexes that aid swallowing, which means the cough, the swallowing, and the gag reflex. If you have dentures, eating while talking excitedly, or laughing or eating too fast, walking, playing, or running with food or objects in your mouth, all common causes of choking. Okay, when we look at basic life support and the airways, we have airway obstruction. And the treatment for this is typically referred to as the abdominal thrust, old term, the Heimlich maneuver. What you do is you tell the person what you're going to do after you've asked them whether they are choking. If they indicate that they're choking, either by nodding or the universal sign, putting their hands around their neck, you stand behind the person who's choking, you place your arms around their waist, you clench your fist, you place it right above their umbilicus, the belly button, the solar plexus. You put your other hand on top of the fist and you pull sharply inwards and upwards because you're trying to get them to expel whatever it is that is causing the obstruction. You repeat this movement up to 5 times and then review. And you keep doing it until advanced life support comes or the victim becomes unresponsive. If they become unresponsive, you can straddle the unresponsive person who is choking. You place your hands, as for CPR, chest compressions, below the belly button, umbilicus, and you push sharply downwards and upwards. And you repeat this movement up to 5 times or until advanced life support arrives. With a respiratory rest is simply the absence of breathing, apnea, and it results from respiratory distress and respiratory failure. Typically, the tool that's used is a bag, mask, valve, ventilation. And this is an emergency skill that provides oxygenation and ventilation until a more definitive airway can be established by advanced life support providers. You will probably be doing mouth-to-mouth or mouth-to-mouth and nose resuscitation, unless you have this device. Now, it's important to remember this resuscitation fact. The brain cannot survive without oxygen or high-energy phosphates, glucose, for a very long period of time. And it's only 3 minutes without oxygen before the brain damage occurs. Cerebral hypoglycemia and anoxia may cause irreversible brain damage if they are now hypoglycemic or anoxic for more than 3 minutes. That's why resuscitation is important to start as soon as possible. Now, when we do the primary survey, this is basically the first look, and you can use what I call the patient assessment triangle, and it consists of A, B, C. A is the appearance, which means what's their body position and what's their level of consciousness. B, what's their breathing? The rhythm, is it regular or irregular? What's the rate, fast or slow or absent? Work of breathing, are they using accessory muscles? Remember, breathing typically doesn't require any work. It's quiet and it's usually unobservable. Work of breathing means you can see them breathing. You can hear them breathing. Sounds, you can have things like stridor, wheeze, absence. Types of breathing can be irregular, regular, fast, slow, a variety of different combinations. But typically breathing is something that we don't really observe. You don't really see anyone breathing. If you see them breathing, it means that there's a problem, unless established that there isn't. Circulation, you're looking at skin colour, warmth, and you're looking at the capillary refill time. Appearance, A. How does the patient look? Have a look. How does she look? B. How does the patient look and sound? C. How does the patient look? How does the patient's skin feel? Are they warm or are they cold and clammy? This assessment tool takes 15 to 30 seconds to do for you to establish whether they're good, bad, which basically means stable, unstable, or whether you should be worried or not worried, and whether you should activate the emergency medical response. Let's go through all the steps for scene safety for you as the rescuer and the patient as the victim. Look around. Take 30 seconds. Is it safe? Is it unsafe to proceed? If not, review your options. You may have to move the patient, the victim, to an area that is more secure and safe. Use standard precautions. Personal protective equipment. It does protect you and it does protect the patient. Rubber gloves is one of the standard issued pieces of equipment that you can use to protect yourself. In step 3, you determine responsiveness. If no response, activate the emergency response system and obtain support from advanced life providers. Determine responsiveness basically means take only 5 to 10 seconds to look for signs of life. Hey, are you okay? They don't seem to be breathing. They're not moving. They don't seem to have any signs of life. Check the carotid pulse, but don't take more than 10 seconds in an adult. If you can't find a pulse, can't feel a pulse, assume they don't have a pulse. No pulse means no circulation. No signs of life or pulse, then commence CAB. CAB is the acronym for, not new now, but for the recommended sequence of events when doing life support. C. Compressions, push hard and fast on the center of the victim's chest. A. Tilt the victim's head back and lift the chin to open up the airway. The head tilt chin lift maneuver. B. Start breathing for them. Mouth to mouth. Bag mask ventilation if you have it. Mask to mouth if you have it. Early chest compressions can immediately circulate oxygen that's still in the bloodstream. By changing the sequence, CAB from ABC, chest compressions are initiated sooner and the delay in ventilation should be minimal. Compressions, let's review them. Hand placement is between the nipples or the intermammary line. Compression rate, hard and fast, which will be approximately 100 compressions per minute. Compression depth, push hard, 1/3 of the anterior posterior chest wall in an adult that's about 2 inches, 5 centimeters. Ensure 1/3 of the anterior posterior diameter is compressed to empty a systole of the heart. You want to empty the heart, push blood out, and do it effectively, because remember I told you, 10 to 15% of normal cardiac output. Do it effectively. Then let the heart recoil. This is filling, diastole. If you don't let it recoil, it doesn't fill with blood. And as a consequence of that, you won't have an effective cardiac output during compressions. Now, as far as the techniques go, you've got 1 rescuer or 2 rescuer compression techniques. One hand, the heel is placed at the nipple line, the intermammary line, and this is used for victims older than 1 year of age. 2 hands, the heel goes in the intermammary line again, mid, victims greater than 1 year of age. Now you can use whatever technique that you like, 1 or 2 hands, as long as you're comfortable doing it. The airway means opening the airway. And the only way you can open the airway is to perform a head tilt chin lift technique. I'm not going to go into the jaw thrust because we're not talking about neck trauma or head trauma in this instance here, but you can review it if you choose to, the jaw thrust maneuver. We're talking about the head tilt chin lift maneuver, and this is where you place one hand on the forehead and the other hand, the fingers lift the jaw, and by doing that you pull the tongue and the epiglottis up. Because remember, when you become unresponsive, your tongue and epiglottis fall back. They're just muscles and they obstruct the airway. You need to unobstruct the airway. The head tilt chin lift maneuver. Breathing, you breathe for the victim. So you can use mouth-to-mouth breathing, mouth-to-mouth and nose breathing, and in this instance you seal and pinch the nose, or you cover the nose with your mouth as well. You give 2 breaths, and each breath is given over 1 second. Slowly, because you want the air to go into the lungs, not into the stomach. You can give mouth to bag and mask breathing, and you can use what is called the E grip and the C grip. Again, you give 2 breaths and each over 1 second each. You want the air to go into the lungs, the airways, not the stomach, because if it goes into the stomach, this could cause regurgitation, vomiting, aspiration. Then you've got mouth to bag and mask. And this is also sealed with an E grip or C grip. If you've got a difficult mouth to seal, then this is an indication for advanced airway management, which we're not discussing in this learn shop, but you can use 2 providers. And this is called the double 2 rescuer E grip, C grip. One provider does the E grip and C grip with both their hands, while the other provider bags. With cardiopulmonary resuscitation, the compression breathing ratio is 30:2, with 1 rescuer or 2 rescuers in an adult. You give 5 cycles, which is approximately 2 minutes, after which you check for a pulse and you change roles because you could get tired and you want to do effective CPR. Now let's review. Can you remember the resuscitation technique recommended for foreign body airway obstruction in a responsive choking victim? Correct, the abdominal thrust. What about activity 2? Explain the abdominal thrust procedure recommended for foreign body airway obstruction in an unresponsive choking victim. This is where you straddle the unresponsive victim who is choking. Place your hands, as for CPR chest compressions, below the belly button umbilicus. Push sharply downwards and upwards and repeat this movement up to 5 times or until advanced life support arrives. What about this activity? State the maximum time suggested that the brain cannot remain viable without oxygen or glucose. 3 minutes. Without oxygen before brain damage occurs. What about the meaning for ABC sequence in the patient assessment triangle for the primary survey? What does it mean? A, B, C. A is for appearance. What do they look like? What's their level of consciousness? B is for breathing. Rhythm, rate, work of breathing, sound, type of breathing. C, circulation, which is skin colour, warmth, and capillary refill time. This is rapid assessment which takes only 15 seconds to let you know whether they're stable, unstable, good, bad, sick, or well. Explain the CAB acronym for basic life support. C is for compressions, push hard and fast on the centre of the chest. A is for airway. Tilt the victim's head back and lift the chin to open up the airway. The head tilt chin lift manoeuvre. B, give mouth to mouth rescue breaths, or mouth to mask if you have it, or mouth, their mouth, and bag mask ventilation. Thanks. That's the end of part 1 for adult life support. Now move to part 2, advanced cardiac life support, which you can see in the Dr Manny Learn shops on YouTube. And if you found this of any benefit, please recommend it to your colleagues, because it was your colleagues that recommended that I do this Learn shop for you. See you in the next Learn shop.